Hey, everybody. Thank you guys so much for showing up live here inside DSN today. We are hosting a live webinar with our great friends, Dr. Briskie and Dr. Taher Dhoon, on presenting large treatment plans through the Colorado Surgical Institute. What's up, gentlemen? How y'all doing today?
Doing really good, man.
What's up, dude? Happy Thursday, I think it is.
Happy Chicago Midwinter Thursday. Yes, I am in Chicago, and I should be walking the floors of the Chicago Midwinter. Instead, I am speaking to you, lovely gentlemen, and to our great friends inside DSN. I'm going to hop over to the festivities at Chicago Midwinter. But before we do that, we're going to be talking about presenting large treatment plans. As you guys know out there, anybody that has ever kind of transitioned from regular bread and butter dentistry with crowns, bridges, SRPs, and restorative onto larger treatment plans, you guys notice obviously the big jump in sizes of cases and the complexity of the case presentation. Today, we're going to talk a little bit more about how to work through those presentations and to get more people to say yes. It's worth noting that Dr. Briskie and Dr. Dhoon have worked in areas where they're kind of blue collar areas, not what you would expect as far as being able to get a high case acceptance for the markets that they work in. And they have been able to become very, very successful with case acceptance, given the fact that, their demographics aren't what you would consider top tier or wealthy. So today, let's talk with you guys about how you were able to kind of evolve into these different types of treatment plan modalities and some tips and strategies on how we get more people to say yes to these types of treatments.
Awesome. Yeah, one thing I want to address first is, you can see that we have a very rudimentary drawing on a pano on that first screen. And that's done intentionally. So what you're going to see throughout the presentation is there's some stuff that is like, okay, you showcase your technology, and there's other things that are done in a more hand-drawn way, which indicates a customization for that patient. So even though handwriting things out doesn't necessarily look as clean, it doesn't indicate to the patient that they're getting a very personalized treatment plan. So yeah, go ahead, Briskie, you can move to the next one. So, and we're going to cover high level here. And then when we get to the very end, we're actually going to run through a few cases. And for anyone who has any questions, feel free to drop it into the chat. And as we see them, we're going to go hop in and kind of answer those questions. But in the beginning, I think we all know this. And then there's a difference between intellectually knowing something and then actually implementing it within your practice. But if you want to start having these $20,000, $30,000, $40,000 days, where you really get to spend half a day with someone in the room, you really have to be able just to spend time with one person and not have 5 other things going on. So if you're a solo practitioner, I think what that means is sometimes you got to have a day dedicated to just these bigger cases and consultations and spending time with people, maybe while hygiene runs and you don't have to do your checks. And if you're a multiple doc practice, it's a little bit easier because then the other doc can run the show while you're intentionally spending time with these patients. But you need a good greeter. You can't have the old school, they're really good at their job, but they're a miserable human being up front. You have to have someone who can stand up, warmly greet the patient, shake their hand, Google them ahead of time. If they're a doctor, refer to them as doctor. If they're 74, that 74-year-old walking in is going to be Frank. So you say, hey, Frank, welcome to the practice. We're excited to meet you. It's like, you got to really separate yourself from a customizable perspective with these patients, so they understand that they're in a different office from the first time that they enter into your building or your establishment. Briskie, do you do something similar in your practice, like with your training on your front office with your greeter?
Pretty much. So I have one person that takes all the implant consults with me as far as running it through with the patient in terms of the financing. But I have 2 people that are trained to answer the phones for any implant consult that walks through. We have 2 different sheets, and one sheet is a onboarding sheet for a new patient where it says claim, chief complaint, and type of insurance, all that. I have a whole different sheet for an implant patient, right? And it has little prompts on it, like, hey, patient gives you a call. what do you say to them, right? And how do you mirror what they're saying? So a patient says to you, hey, I'm calling about my loose denture. And you tell them, well, tell me more about your loose denture, right? And so just more mirroring them and trying to figure out what exactly is wrong is a really effective way to do that. But it's a big art because there's many different scenarios that can happen. The patient could be insurance driven, right? Or they just want to know the price. They're a price shopper, or they have no idea what they want to do. And there's many different scenarios you have to play through just psychologically on the phone call. I've spent the past like 3 months really dialing this stuff in with my staff on how to answer a phone call. And it's an art and it's extremely important. So yeah, I do pretty much same thing as you. In that avenue, yes, but it's an artwork and you need to have specific people that do this in your practice.
Yeah. I think that's actually a good place to start, is before actually the patient walks in through your door. So from the phone call, yeah, having people well trained. What we found out was we have a phone tree where it was like, press 1 if you're a new patient, press 2 if you're existing, press 3 if you're an implant. Well, every implant consultation considered themselves a new patient. So everyone would press 1 and get routed through the general practice. So what we had to do is we had to change our phone tree around and say, press 1 if you're an implant consult or implant patient, or you're calling about implants, press 2 if you're a new patient. And then that routed the phone to the right person who specifically had a consultation room where they can have these longer conversations. So that was one thing that we found out through kind of just beta testing out how to run the phones. 2, it's we routed the phone to the person who had time, who could really truly connect on a human to human level with people, but also had 15 minutes to hear these stories. Also, what we did is we created a video that we would send out to patients ahead of time. So we told them like, hey, here's a video, you're calling about implants, watch this video, it's Dr. Dhoon talking about stuff. You're gonna wanna hear it, it's about 15 to 20 minutes. Watch it before you come in. So now we're preheating every patient that's coming into the practice. Professional videos done with a PowerPoint, it kind of cuts back and forth. So it's like showing some before and afters, and it's kind of discussing like why we're different. Like we use the microscope in our practice. We have a CBCT. We talk about airway. It's edifying the practice without making the person on the phone edify the practice, and really getting the message across. So all of this is done before the patient ever comes to the practice. And then, of course, when we get to the point where they walk in the door, that greeter is specifically, that's their job, is to be enthusiastic for every person that walks through the door. Give them the whole med history stuff and all of that. But then we have another person who's specific to new patients who will come up, give them the tour, walk them to the room, do the comfort menu, all of that stuff, and be in the room with the doctor to do the treatment plan or be that point of contact. So, for example, when I got my LASIK done, the person who did my intake phone call was the person who met me when I checked in, was the person who did the exam with the ophthalmologist, and was the person who did my post-op call, and was the person who did my 1-year follow-up call. And this is like a multi-billion-dollar surgical center here in Colorado. And so I just happened to like chat with the guy afterwards, and he was super professional. I was like, hey man, like how do you run stuff? He's like, yeah, we spend millions of dollars on consultants, and this is the system we created. And we can do that for free. We don't have to spend millions of dollars on consultants to do this stuff. So it's really just finding warm people to welcome them into your practice is, step number 1, and giving them time to do the things you want them to do.
So one thing I'll add.
Do you guys? Oh, I'm sorry.
So Dhoon, one thing I'll add into that for the phone tree, I used to do the same thing, but what I found out as a startup was patients would get confused when you have the 1 and 2, because at that point you have 2 different marketing campaigns going on. So you don't really have enough of a patient base where your patient gets kind of confused on who they're calling. So I no longer I don't do a phone tree. I just have a go to the phone, right? Just the general number itself. But then behind the scenes, there's multiple marketing campaigns going on, right? And right, when my website might look a little bit different on the general end to attract my general patients, then another website will look different on different end to attract my implant patients. But mine's a little bit different as in terms of a startup picture.
Do you guys encourage spouses and significant others to be in the room during those large cases?
Yeah, what we'll do, and it's hard sometimes to find the right words to say to someone without insulting them about like, are you the decision maker? But what we'll do is we'll we ask them on the phone to bring anyone who's a loved one who might want to hear this as well and who supports them in making decisions. And then also, if the patient's younger, it's a little easier conversation. If they're very, very elderly, it's a little easier of a conversation to bring, like a kiddo or one of their adult children to come take care of them, because that's probably what's already happening. When they're in that middle sweet spot of, like 35 to 65, it's a harder question to navigate. But we just try to lightly say in conversation, like, oh yeah, the sun rises and sets. Hey, is there anyone that you want to come to the consultation with you? Sometimes it's a lot of information, and we want to make sure that we cover everything with you. And if they come to the consult and they're not prepared, or they say someone else is a decision maker, we schedule a second consultation. I just don't want to scare them away from showing up the first time by making more rules and stipulations to come to at least meet us the first time.
Adding more obstacles.
The intro phone call, I think it's important to simplify it as much as possible. So don't ask about insurance if you don't have to. So I learned that the hard way. I no longer ask for insurance if you're going to be using insurance on file, like something like that. I don't say that anymore. So anything that could give the patient an excuse to not show up, I don't use. So I only pull on emotional strings, and that's it.
Cool. So let's get into the bones of how you guys do this, the actual structure of what one of these consults looks like.
Yeah. So we'll get the CT and a panel. If time permits, I like for them to go and get perio charting done with the hygienist. So we'll put like a little half an hour block in with the hygienist assisted hygiene column so they can just chart them. Because what's going to happen is sometimes that patient's not ready for reconstructive work. And so it's nice to know what type of hygiene visit that they're going to need so we can present the fees appropriately too. And then for context, we're not going to just talk about like all on fours or all on X's. We're talking about any reconstructive case. This is like crown and bridge. This is multiple modalities. It could be sleep apnea, ortho, crown and bridge implants, all the above. So I like to see if on that day they can get perio charted, because let's say I present a $50,000 case. Well, they're only ready for 10,000. Well, 2,000 is going to hygiene. The other 8's going to some restorative and extractions and triage. And I'm just keeping that patient in the practice because that has increased revenue significantly. Before, what I used to do is blow them out of the water and they either accept or they don't. And then they're my follow-up marketing campaign. But what I found is if I can do a little bit of work for them now, build a rapport, take care of them, I get more internal referrals, but then also my associates get more production doing regular dentistry as well.
Nice. Dude, do you want me to pull up a CT? Because I'm on my computer actually, my work computer.
Yeah, that'd be awesome.
Yeah. Let's do that. Let's see.
And so while he's grabbing that, I think it's huge. So they'll get the CT, and then they'll get a quick little tour of the main floor, and then they go to a consultation room that's private, and we'll actually have a screen that we pull up the CT where they can watch it. And if you can imagine, there's two ends of the desk. So patient here, then there's a desk in between. I have my treatment coordinator on that side of the desk, and I actually sit on the end of the table. So it's almost like a tripod where I'm not sitting across the table from the patient presenting this. I'm actually sitting kind of a little bit on their side. And so that way I can point to the screen. I can hand them things if I need to. It's just like a small psychological thing where I'm not like the opposition to some degree. But we'll go through like all the x-rays with them, and Briskie is going to kind of take point here.
Yeah, sure. So I had a couple that came in. It was one of my first patients, was a couple, and it was husband and wife that both needed arches, and they didn't really know it. They needed something. So I always make the joke. I tell couples or family members, those who do implants together stay together, and then they just kind of like chuckled, like, oh, how cute. We can do our implants together, Ron. Right. So first thing I'll do, I do mine a little bit differently. I start in my consult room while the patient's in the chair, and then Dhoon starts everything in the consult room. The reason is, for me, I use my consult room for pretty much everything. It's my home base right now, and as a startup. And I'd say about 20% of the time, the patient isn't just implants. The patient could be cosmetic or need some fillings or crowns or anything like that. So I want to put them in the chair where I can have an intro discussion and see exactly what they need, so I don't have to bring them back into the room. to get x-rays. Dude does a little bit differently because his thought process says he doesn't want to scare the patient away, right? And the most comfortable place to do a conversation is in a consult room, because that's when they're going to have their guard the most down, because they're not scared on like what the next step is. Because the patient sits in the chair, they could be thinking, oh my God, is this doctor going to hurt me? What's going to happen today, right? All these little things are going on in their head. Well, what could happen in that day? So it's important to frame the discussion ahead of time. So when the patient does arrive, tell them, hey, Ron, today what we're going to be doing is we're going to be getting a 3D scan. The doctor is going to look at your scan in terms of the bone quality and quantity, and he's going to come up with a customized treatment plan for you today. And we're not going to be doing anything. We're not going to poke you. We're not going to do any shots. We're not going to take any teeth out. So it's just purely like informational, right? So I say something, I frame something like that. So then I'll sit them in the consult room. So I'll sit in my consult room. Yep.
One thing I'll also qualify is I start them in the consult room because free consultations have a higher no-show rate. And so I was protecting chair time by running them through there. And if they show up and chair time is available, then I would pivot them to an operatory. Now, if capacity isn't an issue, let's say you got multiple operatories, or for whatever reason you have the chair, you can start them in the chair too. But it's just how I would kind of sequence it, and I've just stuck with that system. It just tends to work. But I mean, it's however you get the result in your practice is what you want to do.
Yep. And I'll sit in the consult room for a few minutes, and I'll look over the x-rays that I just took and the intro photos. So I take intro photos and x-rays of every single patient. And then I'll pull up my CT, and you guys can see the CT, right?
Yep.
Yep. So then I'll just go through. I'm like, if I was to do a surgery, what options do they have? Now, it takes me about 5 minutes now. I'll look at this. I'm like, well, this patient may have an overdenture or overdenture for the bottom. The patient's options for the bottom in this one, because there's really no teeth, but there is good bone. They can do a denture, they can do snap-in teeth, and they can do permanent teeth. On the top, what they can do is a denture, or they can do permanent teeth in this case. So I was like, cool, I already know what the game plan is, because patients don't like us talking in theory, like what you could do. They want to know what you can do. So I feel like a lot of time I would talk myself out of a case, because I'd bring them back and say, hey, I need to get a couple of records or this or that. And you're not seeing me as confident. So if you seem confident in your delivery to the patient, you tell them, hey, this is exactly what we can do. And you walk through them all those options. So now that I'm in the consult room, I'm like, okay, cool. I know what options I have. Now I'm going to grab my models. So I grab a bunch of models. So I have this one's from Neodent. It's in permanent teeth or all on X. I always say permanent teeth. I don't ever say denture teeth. I don't ever say anything like that. I just say permanent teeth. That's all you say. I also have snap-in teeth. That's a model with snap-in teeth. This one's also a Neodent model. And it actually has the exact same inserts that I use in my practice. So I have this one, and this is their snap-in teeth. Then I have my third one, which is a denture. So I bring those three in there. Now, if a patient has a complex case where they really need to get the work done, or they're going to end up in a really bad scenario, I also bring a zygoma model in. And this is where I pull on the thread a little bit, where I do scare them into doing treatment, because I know that if I don't motivate this patient to getting work done, and if they do leave and not come back for another few years and scare them away, they're going to end up with zygomas. And that's not a good thing for my patients. So how do I help people get to the result that they want? I'll also have 2 teeth models. I have a printed arch that comes from my printer, and then I also have a zirconia arch, so that they can hold both. So that way they are going through all the options. They have denture, snap-in teeth, permanent teeth, printed arch, zirconia arch, and then if I need to scare them, I have some zygomas. Right?
Yeah,
So,
and I think the models are huge, because what I'll do is I'll actually physically hand them the model and I make them hold it. So I make them hold the denture so they can feel what acrylic feels like. I make them hold the 3D printed temps. I make them hold the zirconia. And I also say a version of, if you're healthy enough to walk through my doors, you're typically healthy enough to do the procedure, and you should probably consider I call it a fixed full arch of teeth or a permanent teeth. But yeah, you don't call them all on X's or all on 4s. Also, I say, and I don't like doing overdentures. So again, this is just my philosophy. If you do overdentures in your practice, this is not a knock on it at all. They absolutely have a place. But my verbiage is I would prefer to do the arch, and I make them the exact same price. So that way it's not a money thing. It's like a preference if they want removable teeth or not. But I tell them, like, look, the overdentures, in my estimation, are for patients who need the ability to take the teeth out to clean the implants directly. But if you're healthy enough to walk in through the door, you're probably healthy enough to maintain and clean these yourself with a water pick. And I think the fixed full arch makes more sense for you. Seldom is an opportunity or is a situation present itself where the overdenture makes more sense for the patient. And that's usually going to be someone who's very atrophic or retrognathic, and they need more facial support for whatever reason, or they're head and neck cancer survivors, and they need more prosthetic support underneath. So the vectors and the facial support feels better. And those cases are few and far between.
Yeah. Now I'll pull up the CT in the room. This is kind of the first thing I do as I pull this up. I'll sit down with the patient, just interview them. I probably chat for like 5 or 6 minutes, just trying to establish some rapport and learning more about them and trying to feel and see what I can tug on. I'll always ask the patient, hey, what are your goals, right? What are your goals? What can I help you accomplish? And some patients may have absolutely no knowledge whatsoever. Some patients are just coming in for a price quote, right? I also ask them, how many places have you been, right? Some people will have been to 2 to 3 places already. I already know that I'm a competitive price. So at that point, I'm like, heck yeah, I'm going to close this case today because they came from Clear Choice or Nuvia down the street and I'm better than them. We're better than them and we charge less. And they're going to have a home where they can have their hygiene after, right? Because all the big implant companies don't do hygiene after, they just disappear. So I always pull on that thread too. I also show patients how many implants we do. So if I do a full arch, I'm doing 6 implants, not 4. So there's definitely a bigger value add. So once
Dan, can I ask you a quick question? So is there anything in the early part of the conversation that just kind of I guess qualifies this patient for somebody that can actually proceed? For instance, a lot of times people, will get a large volume of Medicaid patients that call the office, and no matter how hard they screen them, they end up in the consultation for an all-on-X, and they don't have the financial ability to ever afford something like this, and they're a better candidate just financially because they can't afford it, that they should probably go the removable route. So is there anything early on that says, hey, listen, here's kind of, if you're looking for something like this, your range is going to be something like this, so you don't end up spending, a half hour with them, not knowing that they're financially incapable of affording it?
Yep, I do. So once I know the exact options that they can qualify for, I'll sit down with them in this manner, and I'll just tell them how many implants that they can have in each area. And I tell them your options are a denture or a snap-in teeth, or a denture and permanent teeth, right? And for the most part, patients are going to be like, ooh, I don't think I can afford that yet, right?
Okay.
I'll also ask them, how much do you think a case like this costs, is what I'll ask them. So if I have a doubt in my mind that they can pay for something, and I've been wrong so many times, but I've also been right so many times, right? So you might have that farmer that has cash buried in his cornfield, or you might have the nicest guy with a suit shows in the BMW and he has no money to his name, right? You don't know who it is. But I'll ask them if they have it. If I'm, how you'll be talking to a patient and you get some yeses or some yas, right? And you don't know if the patient's really saying to you, yes, like confirming that they're ready to move forward, or they're just giving you like a yeah or a yes in terms of just make you like keep talking, or they are unsure themselves. Like a little bit of body language that you're reading for the patient. But if I have an inkling that they are concerned about money, then I ask them, how much do you think a case like this costs? And right after my little spiel. And then they'll say, oh, I think this is $2,000. I'm like, ooh, man, maybe I should present some of the lower cost options on my treatment plan as well. Versus someone's like, oh, I think maybe this could be costing me 12 to 15 grand, or they did a little bit of homework and they're more educated. Then I'll talk to them about the all-on-X's, or I'll pull on that a little bit more. But I always ask them, how much do you think this case costs? How much do you think this costs?
We do something a little bit different and then similar in some degrees as well, where it starts at the phone call. So then my person who's doing the phone call pre-grades the call as a red, yellow, green. If it's a green, they get an 1.5 hour consultation. If it's yellow, they get an hour. And if it's red, they get a half an hour. And so for whatever reason, if a red person shows up, because the reds usually have a high no-show rate, so they typically don't show up anyways. But if they do show up, then we get the CT and the pano and the tour. And if I'm busy because I haven't allocated time to go meet them, we say, okay, great. Doctor's going to review everything. We're going to get you back in. And they'll come show me, I'll be in an operatory, I'll be doing surgery, whatever. They'll pull up the CT on the screen so I can look at it and I'll say, okay, cool, they have all three options. So then Amanda, who will present this stuff, will say, hey, your range could be from 14,000 up to, 52,500. Is there anyone you want to bring to the next consultation? Dr. Dhoon's going to review everything in depth, but you are a candidate. And so that way we can give the reds still an opportunity to kind of see where they fall. And some reds, very, very few, like 5% will ever actually do the arch. Usually they come in as a traditional patient and we do just regular extractions and partials and things like that. Yellows and greens, you never know. And then there's a company called Soft Credit Pull or something like that, where you pay 99 bucks a month or some version of some kind of payment per month. And you can run people's credit based on information you get on the intake call. Now, the thing is, when it's bad, when they don't qualify, it doesn't always mean they have bad credit. But when it's good, it typically means they do have good credit. So it's another screening tool. You still want to invite everyone to the practice, but it helps you kind of distinguish between red, yellow, and green.
Mm-hmm.
Cool. I like that. Pre-grading.
Mm-hmm.
So, and then also when it gets to the Medicaid patients or anything like that, some of them have inheritances and things like that that are present. But again, it's few and far between.
Yeah. So after I know what the patient options are, I'll sit down with them and I'll pull up like a screenshot of the CT, or I'll pull up a pano. Usually pano is the best way to see it, but I'll show them where their sinus is, which is an empty space. I tell them we can't place implants into empty spaces. I show them where the nerve is. I said we can't place implants into nerve because that'll cause nerve damage. And I tell them this is the bone we have, and this is how many implants you can have. Right? Because what patients, I like showing that because you can pull on that thread and, say patient might have been for an all-on-4 or something like that, or a case where you're like, oh no, we place 6 here. You have implants, so you have 6 spots for implants here. So I'll go through that and I'll show them all the areas with infection and I circle them where all the infection is so they can realize, oh my gosh, like I have a lot of teeth with bone loss. I have a lot of infections going on. But right now I tell them, the good news is you have enough bone to do all these options, or you have enough bone to do this specific option.
And one thing I want to just make sure that everyone does is present all their options. Now, so I'll do a version of this because again, Mark, you don't want to have a 10-hour consultation. Mm-hmm. So I go in and my preset routine is shake the patient's hand, sit down, say, hey, how did you hear about us? Okay, cool. And then my person writes down the referral source, put their x-ray up, review the x-ray, and say, hey, I know I threw a lot at you. My job is to make sure you know all your options, and I'm going to throw a lot of information at you really quick here, but definitely stop me at any time and ask me any questions. I used to say, hey, interrupt me at any time. And then I had one person correct me and be like, I'm not going to interrupt you. So then I changed it to say, hey, stop me at any time, ask me any questions. But I do that pretty quick. I review their case and I draw on the panel like you guys can see in front of you. And I draw on it and I really show them what I'm thinking about. But that's like 5 minutes. And then I have a folder that's closed that has our logo on it. And you open it up and there's 3 columns on the piece of paper. Imagine like your, 8.5 by 11 just folded and as a trifold. And so one option is dentures, one's overdentures. Actually now we have 4. One's all on X and one's your 3 on 6. And it just literally says those things. It has the prices on there. And I'll tell the patient, like, look, it's my job to make sure you know all your options. So you can do partials, you can do blah, 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 blah. If you want me to go into detail with any of these, I can absolutely do that for you, but we'd be here for about an hour and a half. So what I'm going to do is I'm going to focus on what I think is the most correct option for you, or what I would do for any family member in your situation. But then also I'm scanning into the treatment plan, the options I've presented, because I had one person have a lawsuit against me, or it didn't ever get that far. It's just she threatened to do that because I didn't present the 3 on 6. And so it's just now it changed the protocol to say, hey, we're presenting all the options as we see them. And I'll say, hey, your 3 on 6 is 70 grand. Your all on X is 50 grand. Your overdenture is 30. Your dentures are 14. And so that way it's scanned into the patient's chart. So if anything does ever happen where they're like, hey, you didn't present all the patient's options, it's like, well, no, we did. It's scanned in there on the date of their consultation.
That's cool.
Mm-hmm.
And so, yeah, nothing ever came of the lawsuit or anything. She just, disappeared or rode off into the sunset, and it hasn't been an issue.
What was her
But on that-
contention? Did she go with a lesser treatment plan? Did you do removable or something and then claim that you never?
No, she did. Yeah, she did a fixed full arch. So she did the all on X, and then she ended up, granted, she gave me red flags from the beginning. She was over complimenting me and calling me honey and sweetie. She's like this old Louisiana lady. And I said that I walked on water and all this stuff, like playing to my ego too much in the beginning. And so I said yes to the case, and I did, upper lower all on X, 6 implants. And then she ended up not being happy with the temporary prosthetics, and we were still working through some of the nuances with it because of her skeletal pattern. And so she went and saw some prosthodontists, and the prosthodontist was like, oh, you should do a 3-on-6, and charge her an extra 60 grand to, do block grafts and add 2 more implants. And so because the option was never presented to her, she tried to bring a suit for it. But again, the surgery and everything was fine. So from that perspective, nothing ever came of it. But it still caused me some sleepless nights, to the point where it was it's worth adding one more line to your documentation to prevent it from happening.
Of course. Yeah, that's a good tip.
So Briskie, do you have an example of like a crown and bridge course or a crown and bridge, like a case or anything that you would present from that perspective, or how you would handle the intake from that patient?
Yes, actually.
So that's your example of your surgical case that comes in, right? Pretty definitive. It's a terminal dentition. The patient doesn't have a whole lot of options. But if someone walks in and they want a cosmetic improvement, they're missing a few teeth, they need a VDO change, maybe there's like some sleep apnea or something to look at. It's definitely beneficial to get like an iTero scan or some kind of scan, including the palate, so you can measure the width or the interarch space between your molars, so you can see if they're constricted. It's nice to look at like a sagittal view in the CT of the patient's airway to see where the soft palate is and see where the tongue is from an obstruction perspective, to see like, hey, if I do a case on this patient, but they have nocturnal bruxism as a result of airway issues with sleep apnea, are we going to be preserving the work that we're doing? So is this the opportunity we need to take to potentially expand the patient? So you can expand them, and by expanding them, you're going to be creating spaces in between all their teeth. Well, then if you do your crown and bridge, then it's super minimalistic, because typically speaking, those patients are worn dentition cases. So they've already done the reduction for you. Now you're creating a little bit of spacing in between the teeth. And so your preps are super feather edge type of stuff. And I don't really do feather edge. I do a small little chamfer. But at the end of the day, it's kind of like looking at the cases holistically, or from a macroscopic perspective, so you can address all of the chief complaints. So it really comes down to having a conversation with the patient and asking the right questions, like, what are you struggling with? How are you breathing? How are you sleeping? Can you breathe through your nose? And seeing if they're a mouth breather, seeing if they're constricted here, seeing if they're retrognathic, kind of like evaluating the whole person. I'm asking how their overall health is, right? Are they on multiple hypertensive meds? If they're on multiple hypertensive meds, there might be something going on from an airway perspective that's leading to an increase in blood pressure, an increase in heart rate at night. So there's all those like negative effects that we know about as well.
Yeah. So this patient came in for a consult, a cosmetic consult, and she said that she's broken these crowns here, these crowns and veneers several times. And I'm sitting in the room like, ooh, I know what's wrong here. This patient's bite is collapsed, right? So the doc, we put tiny crowns on these teeth. So now the teeth are non-aesthetic, they're square, right? And where we should have opened up the bite in the first plane. So what I did was I sat her in the room trying to figure out what's wrong. And she's been to 2 dentists to do crowns on her teeth. Both the times never been talked about why this is actually happening. And then when you look at her, this is her like patient picture, you can see that masseter. Like you can see it bow out and like, whoa, I know what's going to happen on this one. If I was to do her crown and bridge work, she's going to break everything, right? Because she has so much force generated from her hyperactive muscles. So I already know this patient needs Botox, right? And I also know that this patient needs to have her bite opened up, because when I showed her, I said, hey, do you ever notice that you have your bottom teeth come over your top teeth, right? And because of that, your bottom teeth have been growing up here, trying to search for something to hit. She's like, whoa, I did notice that. That's crazy. No one's ever showed me that. I tell her, your teeth are too small. You've done a lot of clenching. So what we need to do is we need to add to your teeth, not subtract to your teeth. She's like, huh, what do you mean? I was like, you've already done the grinding work. So all I have to do is open up your bite. And I showed a couple pictures of the cases where they were small teeth and now they're bigger teeth. And she's like, whoa, how can you do that? And then I showed her on here and I tell her, well, typically what we'll do, I say, we do the top 10 teeth and we go here all the way to here. And then what we do is we open up your bite because your bite is collapsed. So we're going to open your bite up and it's going to add length to your teeth. And we're going to do it from the top 10 teeth. If we try to do it from the top 4, now your bite is going to be open and you won't be able to chew and you're going to break the crowns. So we have to open up all of them. And by doing that, I show them, we're going to be able to add another 3-4 millimeters onto your teeth. And she's like, holy smokes, that's really cool. And then she's like, well, can I just do the top? And I was like, well, actually you can't because you have 100% overbite on this case. So we need to do both the top and the bottom. But most patients have never been offered something like this. They have no idea that their bite needs to be opened up at all, right? Or that they look like, we have masseters like a bulldog and we really need to have some Botox done to fix a hyperactive muscle.
Yeah, I think
That's
Botox
cool
is a
case.
good thing. Yeah, Botox is an awesome adjunct on these cases, especially in the masseteric, temporalis muscles. If you're doing block grafting, Botox is good in some of these regions here, so it decreases the chance of the lowers tearing open because you have like a really thin biotype or phenotype of the tissue in the mandible. And there's a lot of the muscle insertion occurring there. So when they stretch, they pull sutures open a lot. But it also works wonders over here. I do agree with Briskie that doing the top 10 works better. It's way easier to go second bicuspid to second bicuspid versus incorporating your second molars, especially when you're doing your temps, especially when you're opening the video. You have like molar stops to kind of work with when you're setting all your temps. And if you prep the whole arch, sometimes your temps can shift a little bit. So what I'd like to do, and let's say, in this case, I had to crown all 4 molars as well later, I would still do the top 10. I would open the VDO, I'd establish cosmetics, I'd get them into centric relation, I'd make sure everything is fine. And then later I go back in and just prep the molars and then restore them like I would any single molar, or even leave them like a 1/4 millimeter or 1/2 millimeter out of occlusion, because the patients aren't going to notice that they're out of occlusion. And when their masseters fire, you get all that contraction force that's occurring. And if you have that in your temporaries with your molars, it just makes your reconstructive cases so much harder. So really going bicuspid to bicuspid, and this is not a every time, but it's like the most of the time scenario. It saves you a lot of stomach lining on these harder cases.
Okay, so pulling this back to presenting large treatment plans, you clinicians. Not that this isn't totally fascinating, but actually it is. I love the way that you guys think. But I'm gonna pose this question to Briskie, because Briskie, you just kind of set this up, and for a startup, I'm still calling you a startup, but for a startup that's able to get so many leads and to get people that are actually interested in this type of procedure, I know that people are dying to know, like, what does your funnel look like? How are you attracting these people to call your office for these free consultations, to even be able to have a shot at presenting these large cases? Because I mean, if you don't get leads and you don't get people that are, interested in this type of work, you're never going to be able to dazzle them with an awesome case presentation. So how are you doing that, since you just set it up?
Yeah, good question. A lot of stomach lining loss this year. Oh my God.
Trial and error too, right? Yeah.
I spent so much money in different marketing endeavors just trying to figure it out for my area. And it's been really hard. But so it depends what type of practice you want to be, right? And you have to really define that. Are you going to be someone that's just doing a case once in a while? Like, how many are you going to do a year, right? Of these upper 10s or all in X's, are you going to do 4 a year, or are you going to do 4 a month, right? Like, what's your actual goal? Because you have to make that big investment. There is no in between. There is no in between. either you do it or you don't do it, as far as the practice is what I found. And you also, obviously, you have to have the clinical knowledge to do that. So because I have the knowledge to do those cases, I felt confident to just jump right in and market heavily just for these cases, just like you said. So I've changed, I went back and forth this model a bunch of times now. I started off having one website, and my one website was attracting implant patients and general patients. But what I noticed within the first 6 months is I wasn't getting as many general patients because they're all thinking that I was only doing implants or only doing cosmetics. So I changed it now to where my website looks more general based. And now I have about 3 different websites that are microsites. So one will show a website for me doing implants, one will show one for me doing overdentures. And that's allowed me to grow both departments at the same time rather than one at a time, is what I found for at least for my area. But coupling that with a million different marketing campaigns, I have 2 different mailers. I have magazines. I have like I always said, Facebook or Instagram going on, or pictures or testimonials. I have a specific software now that goes through all my leads for cosmetics or implants or anyone that I get. Generally, I add them into a software and I can manage them or send out custom drip campaigns as well. And TV as well. And yeah, pretty much everything, man. And what you're looking for is like an 8 times ROI on your marketing budget. So if I'm spending like 20K a month, I better get like 140, 150. Like that's if it's well tuned, right? But a lot of the time, like in the beginning, you're going to be spending a lot of money, which I'm doing right now. And sometimes it gets scary. It does, because you do things in a little bit of waves. I've been averaging about 3 arches a month as the startup. I just had my 8 months. But it's very scary at the same time to build this, because you never know if that case is going to come in and say yes. But again, that's why you have to set so much time aside for these leads when they come in. And for me, I don't really label them as much green, yellow, red, because every lead is really important to me as a startup. So I try to get just bodies in the door. In the worst case scenario, if they can't afford anything and they can't do anything, I pivot them into getting some free treatment at our surgical institute, right? But so my time is well spent either way. But name of the game, get people in. You're going to spend a lot of money in marketing because every area is completely different. This area is going to be completely different than any other state, and there really is no secret recipe, but trying all of it, and then seeing and really just tracking where your leads are actually coming from as far as like a marketing budget spreadsheet. I know Cody, my buddy Cody Bowles, shared with me his marketing budget spreadsheet. He's a really smart guy, has everything dialed down on exactly how many leads he gets from every single campaign. And I started doing that 2 months ago. Once I was able to open my eyes, the first 6 months, I closed my eyes and I said, okay, here's all this money. Don't look at it.
Yeah.
Let's see what
that was going to be my
I just
follow-up
opened
question.
my eyes up.
Yeah, the tracking was going to be my follow-up question, and the importance of that, right? I've seen a lot of people spend 20 grand a month on, 16 different campaigns, and one of them is working and 15 aren't, but they don't know that, because they're not doing a sufficient job of tracking where the leads are coming in.
Yeah, that
Dr. Dhoon, I think that
you could send out like maybe this month you do this type of campaign, or this month you do this campaign, or you're just trying little things out and tinkering. But you just don't want to tinker too much, right? Because it has a negative effect.
For sure. Dr. Dhoon, I'm going to ask you that question just really quick. What have been kind of the top ways that you've been able to get leads? And I know, just like Dan, you've been doing this over a course of years, and you've been able to kind of narrow down what works and what doesn't. So what in your particular market in Greeley, which is a very kind of blue collar working class area, what's been working for you as far as the most effective way to get the most qualified leads?
So for full arch surgeries, I would say TV commercials have worked really well. So what I did, and I'm not recommending that everyone do this, but if you have a marketing budget and you're okay, like testing out $100,000 for the year, it'll probably cost around 20 grand to record the TV commercial. And you can do this on your own, or you can go with like a company like the Wellness Hour with Randy Alvarez. And so, and consider me agnostic to all recommendations. I'm just kind of talking about what's worked in my hands. So in my area, it's about $500 to $350 to $600 per commercial. Some areas it's $2,000 per commercial, and that may not be worth it for you. But I recorded a TV commercial. I went ahead and ran those commercials in different regions. And so if I'm like on Fox, I'll run that for about 6 months to a year, and then I'll switch to maybe like the ABC channel, and then sometimes I'll go to that in between, that's like, your KWGYN or whatever it is, I don't know. And then we'll run different times. Sometimes it's the morning, sometimes it's afternoon. But typically speaking, if people hear and see me on the wellness hour, they come in already ready to go, and they think that I'm the authority on it. And for clarity for everyone, I mean, you're paying for the recording, you're paying to air your commercial, but at the end of the day, the patients don't view it that way. They view it like you're being selected to be interviewed as an expert on the field. And for the first time I went and recorded, I was really nervous. And Randy and his team kind of coach you through it. But let's say you don't want to go do that. I still think it's wise to go on YouTube and look up the wellness hour and hear, like you can look at mine. I think Briskie, you might have one too. Travis Kendall did a good job. Jonathan Abenheim did a okay job. And there's a couple other people like Dan Holzglaw that did a good job. Mike Picos, I use some of his verbiage as well. And then you can also listen to the ones you don't like and just make sure that like you're not doing that in front of your patients. But what they coach you and teach you is how to speak to patients on a broad scale through television. But that technique is still can be utilized in your consult room. And so I use that same verbiage with my patients in the chair. It's a way to connect with them. And simultaneously, by hearing Mike Picos and all these other experts, it's really refined how I case present. And so it really bridged the gap for me. And that's something you can do for free. And then having like a lot of before and after pictures as well, I think goes a long way. I have an internal referral system now that's pretty robust. So when someone finishes a case, what we found is if I do the case and then I wait 6 months to get the before and after video, they're not as enthusiastic because they've already acclimated to the change. But if I do the pre-surgical video and then I do a 2-week video with their temporaries in place, they're still on this like high, like, whatever, endorphin high, dopamine high of this beautiful change that's occurred. And the vitality still kind of comes through the marketing video. And so I'd like to get videos of patients talking about their experience at the 2-week marker. And of course I get it later down the road too, but that's when you get a really good before and after. Sometimes we'll do a Zoom call with the patient because they're more comfortable at home giving you a testimonial versus doing it in your office. So we just set up a Zoom call and we record it. And I've had a couple of really, really good bits of marketing come from there. So I guess to circle back and answer your question, TV worked well, but it's a slow fuel. I got a bunch of phone calls in the first 6 months, and then it dried up for about 12 months. And then I was like, hey, I'm going to beat on this drum long enough until people know who I am. But it was hard to stick it out. And now I just get I get consults just from the TV commercial. Facebook is your fast fuel. It's like if you pump testimonial videos out on Facebook and Instagram, you will get phone calls. And then it's a kind of a representation of dollars put in equals more phone calls generated. So you can kind of see that, A and B type of comparison. Magazines and different things in your local community with magazines. Like I traded free orthodontic treatment for the owner of this magazine and his children or her children for a 2-pager in the local magazine. And I've generated a couple arches from that. So that worked out really well. So I'm a huge advocate. If I was to say, hey, anyone listening to this webinar and you're going to go home and just do anything, go do some get some testimonials, do a case for free if you have to, get the testimonial videos and get the pre-surgical, the 2-week, the 3-month, the final, get a 1-year follow-up, and make it mandatory if you're doing it for free that you get their family to come in and say a couple of kind words too. And then you can cycle that stuff out 20,000 times over, and you're going to generate your next 20 cases from that on social media. And that's kind of like what I would do right off the bat.
Those are great hacks. I love that. I love that. All right. So we're closing in. We're going to do a lightning round. because that's
Sure.
what we always do on the Dental Promoter Podcast. We always have a lightning round. But the lightning round, the way that we're going to end this is I just want to ask both of you guys your favorite analogy in the case presentation room that you use that's been really effective for large treatment. So, we've all used different analogies for periodontal disease and SRPs and not deep cleaning, but this, or, the tread on your tires is wearing down or whatever. What's your favorite analogy, Taher? Just really quick in the last 60 seconds here.
Oh man, I don't know if I have an analogy that like can signify like this transformation or anything that occurs, but I think what really helps lock it in for people is going to be trying to tie them to who they're doing this for. People are less likely to do things for themselves. Actually, when you walk into our office, the new sign we're creating is like, who are you smiling for? And just like reminding people subtly, like, hey, like there's other people in your life that this will affect as well when you transform yourself. And Mark, I'm sure you see this in people with DSI all the time. They come in and they're talking about like the impact into their families as well. And it's huge. It's like you change the way someone feels about themselves, it'll impact the way they treat their significant others and their kids. So I just try to ask them like, hey, are you doing this for anyone? Is there any reason why you chose to call me now? And I try to like have them mentally go and think about that person because they're more likely to do it, or have that person come to the consultation room because I've had the spouse be like, honey, like you got to do this. I know it's expensive, but you got to do this. You've been dealing with this for a long time. And so that human connection component is what gets me a lot of cases. I don't really have a set analogy.
No, I like that one a lot though.
Okay, cool.
No, one-liner, go.
Oh, my one-liner is I try to like edify my experience. So I'll say, yeah, 10 years ago when I was doing this, we did it this way, but it's really good that you're contacting me now because the technology and things we have available make it that much easier. And it's actually less expensive than it was 10 years ago. And you can't say that about a whole lot of different procedures. So, or I'll say, hey, I got enough gray hair to know what I'm talking about, but not enough where I'm going to retire anytime soon.
That's good
so
too.
those
I like that.
some of my go-tos. Yeah.
Okay. Dr. Briskie, do you have an analogy or a one-liner that we can close with?
Yeah. I like to pull on insurance because that's like the biggest thing that people talk about is insurance.
Oh yeah, I love that.
So I always talk about how everyone's like, hey, how much is my insurance going to cover? And I said, great question. I say, when you use insurance, we are legally obligated to charge for what we're doing, right? If we don't, that's called insurance fraud. So we don't want to do that. So when we use your insurance, I have to make an itemized list. That means that we're going to do extraction, crown, implant. And I say, then insurance gets to set the fee. If we go off of your insurance fees, now your case is going to be very expensive. I actually charge way less money for my cases in general. So what I advise you to do is not use your insurance for this. However, I'm not saying don't use your insurance. I want you to use it, but use it for your cleanings, right? So I'm trying to dispel the insurance headache, and I say the same freaking thing every single time. I say it just like that because I want the patient to be like, yeah, insurance sucks. Don't use it, right? Then they're like, oh yeah, but I also want to use it for my cleaning. I'm like, cool, sweet, score, right? Like now it's a win-win because all of
That's cool.
True. And everything that I said is true. It's not false. It's true that insurance fees would be higher if you use insurance. However, I don't want them to use it because it will hurt them. But I want them to use it on their cleanings because it will save them money. I say that every case, and I think patients really instantly diffuse it. And I say that, I don't have my staff say that, because if they talk about insurance, it seems like they're fibbing. But if I talk about it, then it doesn't seem like it's a lie.
Good stuff. All right, that was a solid packed hour. Thank you guys so much. We went all over the place, but then closed it off strong. Really appreciate you guys bringing the heat. Ashley, is there any way that you want to close this in particularly reminding people about their CE?
Just check the webinar chat. I did send the wrong link earlier, so check that second link and fill that out to get your CE. And yeah, thank you guys so much.
Thanks for hanging in there till the end. All of you live participants, that was awesome. And Dr. Briskie and Dr. Dhoon, as usual, thank you guys so much for all of your generous and valuable information.
Yeah, thanks, Mark.
Take care, guys. Have a great day.
Bye-bye.